Good afternoon, everyone. Happy Wednesday. I think I'm now broadcasting. Salim has given me the thumbs up that we're broadcasting to a number of people who've joined us online. For everybody out there across Australia, there's also about 30 to 40 participants here in the audience at the National Centre for Immunisation Research and Surveillance. So thank you everyone for joining us today. Before I start, I would like to very much acknowledge the Darug people, the Aboriginal people of this land, the traditional custodians of where we are standing right now, and I'd like to acknowledge their elders, past and present, and indeed any Aboriginal people in the room today. So we are very, very fortunate today to have the presence of Professor Nikki Turner from New Zealand. And she has an extremely extensive bio, but I'm not going to necessarily read all of that out. But Nikki is a long and old friend, and we had her speak at the NCIRS 20th anniversary as well. It's always an absolute pleasure to hear her. And we know that she is the founding director of IMAC, so the Immunisation Advisory Centre in New Zealand. She's a general practitioner, an academic general practitioner. She's an associate professor at the Division of General Practice and Primary Care at the University of Auckland. She's particularly interested in immunisation, primary health care and child health, preventative child health, and indeed child poverty. And she is a member of the New Zealand College of General Practitioners Child Poverty Action Group, as well as, I think importantly for us in immunisation, being a member of the World Health Organization Strategic Advisory Group of Experts. So, you know, Nikki is lucky enough to get on a plane and regularly fly across to Geneva in her role there. But we've had a discussion about today's topic, and we're going to be talking about equity. And I think, given New Zealand's excellent track record on you know, addressing equity and talking about equity in New Zealand, that's fantastic to hear from Nikki, but she's also going to give us a global perspective. And I would like just right up front to say to our audience both here and also online, please, as with past seminars, do send through any questions. We'd be really fascinated to hear your thoughts and your comments about equity with respect to immunisation and prevention of vaccine diseases, you know, vaccine preventable diseases in Australia. You know, how can we better, you know, look at equity in this country? So, Nikki, thank you very much, and we're very honoured to have you.
Thank you. Thank you for that very full introduction. Kia ora koutou. As the Manahiri, we are the visitors from down under. Thank you so much for the invitation today. And I would very much like to acknowledge the people of this land. And I'd particularly like to thank the NCIRS for their lovely hospitality and my free lunch. So it's lovely to be here, and it's great to have the opportunity to come across. And thank you for giving us your time, for those of you present and for those I'm talking to in some other discombobulated part of Australia. Thank you. So this is one of my favourite topics to talk about, the issue of equity. New Zealand has not cracked the equity question, but I think it's important for all of us to raise the issue and continue to raise the issue, because equity continues to be a challenging problem, and I'm sure everybody in the room knows the difference between equality and equity, that we're not looking for equality here, we want equity of outcomes. So I was going to start from a bit of a history around the New Zealand coverage story, and now some of you may have heard some of these early stories from mine, and I apologise if you've heard it before. And I would like to point out that this is a flag with less stars on it, just in case we were getting muddled up. I always thought we should be part of Australia, really. We could just add a couple more stars and it would all be fine. So anyway, the history of New Zealand coverage was originally pretty abysmal. As you can see, back in the early 1990s, New Zealand, this is fully immunised at the age of 2, New Zealand had a very poor record. Now, what we're incredibly good at doing in New Zealand is writing reports. So we wrote loads of reports. It was really cool. We even wrote priorities for action reports. So we were really good at writing reports. And then one day we grew up and realised that to actually improve things, you need the right tools. So New Zealand finally figured that out and put a tool in place. So this is, what's our NIR? Yeah, National Immunisation Register. So we put that in place there. Now, there's a bit of a lag phase, but this essentially I don't think we suddenly vaccinated heaps more kids. This is just that we figured out how to count them better. So suddenly our coverage went up miraculously. Now, alongside the National Register, we also put in place national health targets. So this is putting in some of the key aspects to make a system work properly. And it worked very effectively, both having the tools and the targets. And New Zealand coverage improved really well. And what I love about our country is once our coverage improved, then we decided it was a national disgrace and had a parliamentary inquiry about it. Isn't it lovely? But we got there in the end. So we finally got improved coverage. We were getting close, and I think at times we even beat Australia in our coverage. But it's been, tagging along similar to yours since. So we thought, aha, we're getting this right. Now, one of the interesting things we did manage to do with improving our system was also close some of the traditional equity gaps. So this is looking at a measure of socioeconomic deprivation. New Zealand has a small mesh block measure of socioeconomic deprivation that we can match to immunisation coverage. And you can see that if you look at poor to rich, so the kids in the richer areas are DEP 9 to 10 and those at 1 to 2, you can see that at the age of 2, we almost fully closed the traditional equity gaps. Now, I think everybody here is aware that any primary care service delivery suffers from equity gaps in terms of access and delivery of services. So this, I think, was a real winning story. And if you look at any country in the world, you'll see these equity gaps. Now, the problem is if you look a bit harder into equity gaps, you can see the story's not that simple. So the New Zealand primary care vaccination program is 6 weeks, 3 months and 5 months. So if you measure coverage at 6 months, that's quite a tight measure. That means that your kids have got to have had their 3rd vaccination by 6 months. So it's a measure of timeliness. Now, when you measure timeliness, you start to see the equity gaps are more obvious. So even though we did close the traditional equity gaps around ethnicity and socioeconomic deprivation, when you look at timeliness, you can see they're there. And there's all sorts of obvious reasons why that would be the case, that children, particularly from Māori ethnicity and children from low socioeconomic depth, for a whole lot of barriers would have more trouble getting on time. So we're aware we've had a timeliness problem. We've put a lot of effort into the timeliness issue. We shifted the national target to 8 months rather than 2 years to push the issue around timeliness. So we felt like we were doing pretty well. We were on track. It wasn't perfect. We've still got gaps, but we could see that we'd made an enormous difference. So what were the key ingredients to making the difference? And firstly, you got to believe you want to do it. And I think that was the first message, that somewhere New Zealand grew up along the way and decided they wanted to do it. You have to have feedback loops so you know what you're doing. So New Zealand put a lot of effort into feedback loops from the national to the district level, from the district level to the local level, and to the individual provider. So as a GP, I get told what my coverage is and what the coverage of the guy down the road is, and my God, he's not going to do better than me. So, it's quite healthy competition without really a lot of extra money in it at all. There's a little bit of financial incentive, but almost all of it's quality incentive. So they work. We've put a huge amount of work into frontline training of frontline healthcare providers. It's probably our biggest plank, is that we trained frontline vaccinators and we continue to train them and update them. And I think a confident, supported frontline healthcare provider with an engaged relationship probably makes more difference than anything else we've ever done. Systems. It's a very boring story, get your systems right. We needed the tool of the National Register. We needed to know where our children were and then to follow them up. So there's a big push in New Zealand on getting the children enrolled at birth or as soon after birth as possible. So the children are enrolled, they're engaged, the provider then needs to act or inform someone else if they've lost the children. So you've got early enrolment, you've got a universal base to work from. You create engagement with the provider early on and you've got a trusting relationship. And then, of course, all your systems. 20 years ago, we didn't even send out pre-calls or recalls, so we've changed a lot over the years. Effectiveness use of the IT. Effective use of the practice management system. Luckily in New Zealand, as soon as you vaccinate, it goes straight through to the National Register. It's very convenient. So a reasonably clean system. And then effective interacting between the providers and the outreach service. So when you lose that child at 5 months and they haven't turned up, you send the outreach services out to them, so you speed up. Now, what we did discover is that we got a lot less anti-immunisation and a lot less vaccine hesitancy over the years. And I think one thing that we have learned is if you normalise a system and make it work well, you've got the majority of the country buying into it, then you've normalised this is what you do. And we used to get probably some of the angriest anti-immunisation in the country, and they weren't all from Australia. It used to be pretty hot, and it's been less hot over the years. Now, obviously, there is an international problem with vaccine hesitancy. But on the whole, if your system's running well and there's confidence in the system, you are minimizing the challenges around vaccine hesitancy. You're normalizing this as this is part of healthy, normal child rearing. So we thought we were doing all right. And just to back up our original data, this is some unpublished data just showing at what level are the major determinants of improving immunisation coverage. This was a study that was looking at immunisation coverage at the general practice level. Now, if you just eyeball those, these are all the determinants that are related to aspects within the practice, like sending out pre-calls, like getting your systems right, the nurses, the doctors, and the caregivers. Now, what you can see by eyeballing that is it's actually your systems that matter more than anything else, and why we should never forget about the caregivers and the community. Interestingly, if you get these things right, it's actually easier to get the community issues right. A lot of systems go the other way around. They put a huge amount of efforts into the community and the public and the health promotion, but they forget that on most of the issues are systems issues. So I always remember that. Anyway, we thought we were doing okay, you know, and we thought, okay, this is all right, but what happens next? Now, one of the problems is, I think we've seen this internationally all around the world, that coverage doesn't necessarily get sustained the way we hoped. So what we have seen more recently in New Zealand is a drop-off in immunisation coverage. Now, as you will see from that chart, it's dropping off in the kids from their more deprived backgrounds. So we're seeing a dip in coverage, which is actually quite marked. We've lost about 3 or 4%. And of course, as you would expect, when you see a drop in coverage, your equity issues start to become bigger and bigger. So we're getting some drop off, particularly for Māori. This group called Other is often, some of this is actually our refugee migrant people, and some of this probably is recording on the NIR. So we're not entirely clear about what the drop off in the other group means at this stage either. And once again, you can see it even more clearly when you hit the timeliness markers, that New Zealand's seeing quite a dramatic drop off in our coverage. And once again there. So, you know, what is going on? What has changed? What is different? Well, firstly, New Zealand hasn't really put a lot more, you know, we put effort in, we thought about it. And then to be honest, I think they thought, you know, they'd cracked it. Whereas I actually think there's a lot of provider fatigue going on. There isn't extra money and funding and support going into the system. It's like, this is what you do now, guys, you know, and it's like we've stopped getting the positive reinforcement. There's an awful lot of competing demands in primary care at the moment. And the remuneration hasn't changed, it hasn't increased. So I think we've kept the same old recipe and we haven't freshened it, would be my feeling. The communities, New Zealand is seeing an increased entrenched poverty, like many countries are seeing at the severe end. And that has quite major effects on public health programs. But also there is a changing social environment that many of you are very aware of. We've got a lot of 2 working parents now. So, you know, to decide that you're going to take along your children in the middle of a working day when you've got 2 working parents is becoming very difficult. Our primary care hasn't responded to that well. There's a lot of social media out there. I think social media is polarizing people and people's views. So you get disgruntled people, and now you can amplify one disgruntled person into 1,000 very quickly in a way that we probably couldn't 20 years ago. And I also think there's a real thing around changing expectations on parenting. Nowadays, as a parent, you have to feel you know all the answers yourself. And there tends to be less reliance on the support from the experts. So when I get a lousy haircut, I don't learn how to be a hairdresser. I go to another one, you know, and I'll keep working at my hairdressers, but I don't learn how to be a hairdresser. Because I think our parents now feel this responsibility to take on Google and become an expert themselves rather than rely on the support of the experts. So I think this is challenging for parents. And then finally, our systems have remained inflexible. I think our systems need to change with the environment. So I wanted to touch on the narrative, because I think we have to hear the stories to really know what's going on in our communities. And I think we probably don't talk the stories enough to learn the systems problem. So this is a story from one of my client groups. I've worked in very low income general practice for a long time, and this is not an unusual story. So this is a young baby of 7 months, presents to me on a Monday morning and admitted to hospital with severe pertussis, under vaccinated. So it seems a fairly clear story of an under vaccinated child. And you go, oh yeah, we've missed the vaccine on that child. But as usual, behind the story is a much deeper story. So it's a child of a young mother, a mother with limited education background, a mother with a history of shyness of authorities and a range of problems herself. The father is AWOL because he's in jail. It's a very large family. And also they've been hit by a bit of sort of over the Coomera vine conversations that have made the mother even more fearful. So, and also it's a terrible housing situation, which is not uncommon in these situations. So, you know, it seems obvious why this child gets sick, but actually when you tease it out, there's a whole lot of issues within the story, and it's not just about being under-vaccinated. So, you know, you can think of how the infection is spreading around that household. You think of why that child gets more sick than my own child. You can think of reduced access to healthcare services, and then you can think of the broader social environment. All of these things are impacting why that child was unvaccinated. So I cannot just fix this by putting more outreach services in place. There's a whole lot of issues going on that if we don't start resolving all of them, we're never going to get back to closing those equity gaps. So that's the story behind it. Just my interest around poverty in New Zealand in particular, poverty in children has got significantly worse, and I think that certainly impacts on our public health programs. So I think we need to be very aware of the community challenges underpinning some of these things. And I also think the modern social world, the sense of overload, and, you know, how many in the room have not kept up to date with their cervical screening or their mammograms? I wouldn't like to admit this in public, but I'm overdue my cervical smear at the moment. And a lot of this is, and I've got less excuse than many for why I haven't got up to date. But when you have a lot of overload and a lot of challenges, you know, public health preventive things are way down the list, let's be honest. Now, alongside that, I think we really do need to think quite hard about the changing social world. So we've already mentioned, you know, Mr. Google, bless him. You know, I think this is a real challenge, that if you're a bit suspicious about what your healthcare provider has told you, you go out and check it with Mr. Google. Now, the thought that social media is broadening our horizons is actually probably the complete opposite. You know now that if you've taken a holiday to Spain, you will be flooded in the next 6 months with advertising about Spain. And the same is happening in many ways. So if you put in some anti-immunisation rhetoric into your internet search, you will be flooded with people of that like-mindedness. So in many ways, social media is actually polarizing and narrowing our viewpoints, not broadening them. And I think many people are very unaware of that you don't do a search and instantly get a broad answer to your question. You tend to get narrowed down very fast. So I think this is quite a challenge for us. And of course, the whole problem behind this, and this breaks my heart, isn't that sad? Did you know what happened to the dinosaurs? Isn't that so sad? So, I mean, the real problem is we need to be able to communicate, and we're trying to communicate the absence of disease. So it's a really dumb product to communicate, you know. I mean, we should be in a different job, shouldn't we? Of all the things to try and communicate, the absence of something is a bit of a challenge. But it can be done. Now, I'm sure many of you have seen these sort of pictures. These were people lining up for polio vaccine in the 1950s. You know, community demand does and can happen. So we appear to be missing the boat somewhat on our community demand side of things. Now, to be honest, I think the core of a lot of this is trust. So it is now very much an individualistic world where an individual feels they have to make their own individual decisions for themselves, for their children, for their own small family. And the concept that we are making these decisions collectively as a community is a lot weaker than it used to be. And I mean, you know, we can mention Mr. Trump all we like, but in the end, I think he's a product of the modern environment, as is Brexit. That the modern environment has shifted quite dramatically. People are feeling disenfranchised and not heard. I do believe this is strongly affecting our public health programs. So then when we think of trust, obviously we can do a lot to build the one-on-one trusting relationships. That has to be built into our systems. So the provider-patient interaction is absolutely core to everything we do. But also probably more and more we need to hear the local community narratives. And then more and more, we can't do a lot about the broader international ones, but maybe we need a dialogue within our own countries about what is happening with trust. So this is the sort of thing we see all the time. You know, these are individual people who do not believe every country in the world's public health program is correct. You know, these people do not believe it. And so they get together and their own voices are an earworm to each other. So vaccine hesitancy comes from that background. Now, I think vaccine hesitancy is not a single issue. It's a range of determinants go right across the system. So I think when people talk about anti-vaccination or vaccine hesitancy, we have to be very careful that we don't narrow it into one viewpoint. Now, coming out of the SAGE report on vaccine hesitancy a few years back now, many of you will be aware of, is these different factors around factors that influence decision, the 3 C's as we call them. Now, you know, one could say convenience is actually nothing to do with hesitancy, but you look at the significant overlap in all these 3 things. So you might have a family that don't actually believe the disease is a risk to them, so they have some degree of complacency. They have had a bad experience with the healthcare provider, so they have some degree of lack of confidence, and then it's bloody inconvenient to go middle of the week to get the kid vaccinated, and it'll be a mixture of all those reasons why the child does not end up vaccinated. And just to assume it's in any one ball is not usually correct. So I also just wanted to focus on the fact I've been talking about equity gaps for children under 2, but equity gaps come in many forms. So I know Australia, like New Zealand, is looking at the whole of life vaccination program now, and the more we look at vaccination programs in the elderly, the more we see equity gaps too. We've got a significant equity gap in our elderly people across socioeconomic groups and ethnic divides. Of course, there's geographical challenges. I love that picture. Have you seen that one before? This guy's delivering vaccine to a remote part of the world. That's the way we should do it. So you have to be athletic to take on that job. Yeah. And so there's all sorts of other equity gaps. You know, pregnancy vaccination, we've got significant equity gaps in our country. This is another of my favourite pictures. Does anyone know what that creature is? I know it's not a rabbit. It's not a chinchilla. No, it's actually a guinea pig. It's an intrauterine growth retarded guinea pig. Doesn't it break your heart? This poor little thing. So, you know, there's inequities in all sorts. He looks like a rabbit, doesn't he? So the high-risk programs, you know, a lot of high-risk people miss out. And, of course, the modern challenges, you know, are the multiple comorbidities. In my own general practice, I see a lot of low-income elderly, and they can often have a huge amount of comorbidities. And we're a little linear in our thinking. So we'd go, if you're a severe asthmatic, you've got more risk of respiratory disease. But what if you're a mild asthmatic and you drink too much and you're overweight and you've got hypothyroid as well? You know, you've got all the added effects, and we haven't got clever enough yet to figure out who's at particularly high risk. So we're still a bit linear in our thinking there. So I also highlight the New Zealand HPV program. We are not doing anywhere as well as Australia in an HPV program. We get overall about 66% fully immunised. But what is really interesting in this case is that we've actually got a reverse equity gap. So it's delivered school-based program like it is in Australia. And what we have shown since the start of the program is that the school-based program delivers more effectively to Māori and Pacifica children than it does to New Zealand European. Now, that's the reverse of other programs. So why is that happening? Why have we managed to create a reverse equity gap in this case? Well, we've got a whole lot of thoughts around that. But I think the other side of the equity gap in the HPV program is firstly is what is happening at the school-based level. Have we got our promotional material wrong? Is it pitched so that New Zealand Europeans are more relaxed and not worried? I mean, clearly New Zealand European girls don't have sex in the way that Māori and Pacifica ones do. You know, I mean, what is going on in the thinking and the promotional bit here? I suspect some of it was in our original promotional material, but also there's significant regional differences. Now, we're in a country that delivers the same program across the whole country, with the exception of Canterbury. We deliver pretty well an identical program, and you've got enormous regional differences. So there's a lot of interesting things going on, as well as the ethnic differences. Now, of course, the reverse of that is the drop-off from dose 1 to completion. We used to be a 3-dose program, and now it's a 2-dose program, but there is a big drop-off in completion for Māori and Pacific, whereas Asian and New Zealand European there's not. So different drivers for different aspects of the equity here. So anyway, that's moving away from New Zealand. If we thought we had enough problems, there's a few more when you start looking internationally. So if you look a little bit broader than our own little nation, you can see that the world has also got huge amounts of challenges. So this is the Global Vaccine Action Plan, which has goals for 2020. Now, disappointingly, there were 6 goals, and only one of the 6 goals was met. And, you know, you could probably predict which one was met. The goal that was met was the introduction of new vaccines, because it's really cool fun to add in a new vaccine. It's really interesting. People like it. It sounds really cool. But to fix a cold chain or to find a kid in a remote village is way harder, or to get rid of maternal neonatal tetanus is much harder. And so the really core boring stuff has not been happening. So yes, we managed to get new vaccine introduction in there, but there's a lot of things we haven't done. So we're still struggling to finally eradicate polio. We still have neonatal tetanus, which is an international disgrace. We should not have neonatal tetanus. Our global vaccination coverage, this is down here, GTP3 is usually the measure they've been using about the global vaccination coverage. So the world did really well for about 15 years in getting coverage up to about the mid-80s, and that it's stagnated since 2010. It has not improved at all. In fact, if you took the Indian coverage out of this, because Indians doing well, the coverage has actually dived internationally. So, you know, you can see that we did well for the public health program, a bit like the New Zealand program. There's a whole lot of fatigue going on, and it's actually going backwards. Now, even in the stuff we do well at, we don't do that well at. So this is a picture of new vaccine introduction for the HPV vaccine. And as you could predict, who is missing out on HPV vaccine currently? It's pretty sad, isn't it? You know, and who actually needs HPV vaccine? Which are the countries that don't actually have cervical screening programs in there? You could map in, it was the countries who had cervical screening programs that introduced HPV vaccine first. So internationally, this is a disgrace. It's been great for us, but it's terrible for Africa and terrible for large parts of Asia. So here's some of the feedback that we've been having from our SAGE group around the failure in the Global Vaccine Action Plan. So there's a whole lot of reasons for this. We've got economic uncertainty, conflicts, natural disasters, a lot of displacement and migration. We've got concerning signs of complacency. There's inadequate political commitment. And as we know, there's growing levels of vaccine hesitancy in some parts, and a lot of stockouts, which actually lose a lot of community confidence. So, you know, here's some of the things that are being fed back at the moment. 2/3 of unvaccinated children live in fragile countries or those affected by conflict. And if you look at Syria, they saw the sharpest decline in vaccinated children, with coverage falling by 38%, and Ukraine coverage dropped by 33%. This is a nightmare. And of course, we all know the situation in Yemen at the moment, that there's one of the worst cholera epidemics on record, with over 1 million suspected cases. A huge amount of people receiving 2 doses of oral cholera vaccine in a whole lot of countries because of cholera outbreaks. And many of you will be aware that diphtheria has been resurging around the world at the moment. So we're seeing quite a big outbreak in diphtheria in many countries. Many people of you will be aware of the outbreak amongst the Rohingya refugees at the moment in Bangladesh. So there's a lot of challenges going on. And I guess when you look at the numbers and you look at the top 10 countries with the most under or unvaccinated kids, they're in countries with lots of people in them. So the problem is mostly within our countries with large population bases. I think many of us will have heard of the DRC challenges at the moment with Ebola, but the DRC have got huge challenges with their whole national immunisation program. There are huge numbers in Nigeria, India, Pakistan, Indonesia, and Ethiopia as well. Now, the worries about these countries is they've been very much supported by the polio resources. So the world has got together about polio. Polio's captured people's imagination. There's a lot of resourcing and support for polio. As we're on the home straight of polio, those resources are likely to vanish. Some of the African countries say that 2/3 of their immunisation program is supported by polio resources. So we've got enormous challenges up ahead with those resources vanishing. So clearly right now, there's a huge global challenge out there around immunisation and the systemic weaknesses that are limiting access to vaccines. So we see the need to broaden the dialogue, which is why it's great to talk to everybody here today, because this is an international challenge for all of us. We need to align it better with the Sustainable Development Goals, with universal health coverage, and interestingly, still on the table is the battle against antimicrobial resistance. So the answer at the moment at the WHO level is, well, what we need is a multi-dimensional system-wide approach. It sort of sounds easy, doesn't it? But, you know, how the hell do you start that? So some of the early draft recommendations is to look at multi-dimensional assessments in countries experiencing the greatest difficulties. So there's a spelling mistake there. And to take a strong focus on monitoring and evaluation frameworks to support effective implementation. Well, how do you make that happen? I mean, nice words, sounds great. How on earth do you make that happen with all the challenges in the world at the moment? Well, firstly, what we do know, and we know not just from the New Zealand story or the Australian story, but every story you look at, is do not take things in isolation, but take a systems approach to this. And the systems approach has to apply at every level, and it has to have the quality feedback loops within it to know what you're doing. If you don't take a systems approach, you don't even know where you're going. And the starting basis, and I'm sure everybody is aware of this, but don't always articulate it, is to look at a universal base and then proportionately more support. So if you do not have a universal base, you don't know where your kids are. Can't even find them. The number of countries in the world that can't actually figure out how many kids they've got. We have that in our adult population. We don't even know how many adults are missing out at the moment, so we're not taking a universal base to our immunisation approach. And once you have an universal base, then you can proportionately identify who needs extra support. That really is the only way to effectively close equity gaps. We've known for a long time that targeted programs alone are not very effective. I've never yet seen a targeted program that has high uptake, because you don't know who you're targeting, you can't find them, and they usually don't want to be found. Whereas when you take a universal base, you've got a much better chance. So my starting point at this moment is historic approaches, traditional public health models, up till now worked really well. I believe that their lifetime has come to an end, and we need to look at new ways to revolutionise and think much harder about making effective systems. So I think Winnie the Pooh had the answer a long time ago. So if the person you're talking to does not appear to be listening, be patient. It may simply that he has a small piece of fluff in the ear. So I think at the moment we have a small piece of fluff in area that our traditional models have worked really well, but they're not going to continue to work without a bit of change. So what's the answers? Well, sadly, I don't have all the answers. That's very disappointing. So I've got a few small suggestions. So as a member of SAGE, I've been working with a small group of people around this issue, and one of the things we are suggesting for the Global Vaccine Action Plan is to look at implementation science and complexity science. Now, I don't know if any of you here are involved in aspects of complexity or implementation science, but it's a ballooning new area of science at the moment. And it's complementary to our traditional public health models. It doesn't take over, it builds alongside. And it's looking at solutions to problems with multiple variables. And it's often uses predictably unpredictable consequences. There's a lot of different models and frameworks out there, but there is a lot of science in this area now. But the key principles behind taking this sort of approach is to acknowledge that this complex story. And even if you go back to the micro-narrative of my patient I presented, there's a lot of complexity in any one story, and to acknowledge the complexity rather than denying it, to prioritize your approaches to management, and to consider innovative solutions drawn from a variety of sources and not just use single sources. So some of the complex system thinking has come from quality improvement frameworks, the traditional continuous quality investment cycles, or the plan, do, see, act, which is those cycles where you have a go at something, you review it, you have another go. You're looking at a bottom-up, a self-reflection, a appreciative inquiry. You're looking at a flexible adaptive response, much more local ownership, and listening to the local voices, taking local ownership, having some degree of participatory action. To be honest, with a traditional public health program, you can't run full participatory action. You need to have an adapted participatory action where you do get some degree of local ownership, but you still absolutely need somewhat of a vertical program. It uses multiple narratives. It puts the stories together from the different perspectives, and you create new times of action. Now, this is not going to answer all the problems to the Global Vaccine Action Plan, but we believe this is a way to start listening to the communities at the different levels and hear the voices and put the pictures together to create more effective solutions. So one of my colleagues in a very poor African country pointed out to me that they are reliant on the funding from the supplementary immunisation activities for measles to keep their childhood immunisation program going. The donor that is giving the funding for the SIAs wants them to do effective SIAs. They need the funding for other reasons. Now, this is the sort of science that would walk through why you're getting disconnects at many levels in the system and why things are not progressing. So, Can we use these approaches to support the Global Vaccine Action Plan? I believe we do. We've got a few small problems. We've got enormous inequities in the world. We've got some very fragile countries. We've got conflict. And we've got areas of huge population growth. We've got countries that still can't even predict and don't even know how many children are within the countries. And there's an enormous amount of displaced populations at the moment. And more than that, in these big countries, there's some very hidden subnational inequities. So they can look like they're doing well, but when you drill down on the data, there's enormous inequities within the country. And I think my final comments would be around just keeping a broader community headspace around the whole of life, and not just to focus on the childhood immunisation program. So New Zealand's doing reasonably well on our childhood immunisation program, but we're not doing so well on adolescents, and we're actually not very sure how well we're doing on adults. So we're certainly moving our literature now. When we express the immunisation program, we start from pregnancy and we go through to elderly, and I'm sure you're doing the same here, is to move the dialogue away from childhood immunisation program to a whole of life approach. Now, what I haven't included in this one is recognising people with comorbidity and complex other issues. But I think we do need to think much harder and much more broadly and put it together as a community. So thank you for staying awake. My final conclusions are that don't lose sight of the fact that we've made incredible differences with immunisation programs. I think, you know, we need to keep that in sight to keep up community demand. We need people to remember what polio is like, what these diseases are like. We don't want to lose sight of the success to date. But we do have to recognise that progress has slowed. It may be just a natural life history with programs that progress does slow, and you need to revolutionise and think again. And I think some of the approaches that we mustn't lose sight of is the principles of a universal base, for reducing equity gaps, and using the right tools within your universal base to reach out to the higher needs population. Never forget the importance of thinking harder and harder about your systems being effective. And part of your effective systems is that you will then maintain trust at every level within the system. Vaccine hesitancy should not be seen as a standalone issue. It belongs within the greater dialogue. It's not an isolated issue. It lies within the system and the trust within the system. And then finally, I do think that there are exciting new science approaches that we hope will help and add around complexity theory and implementation science, the micro-narratives, the stories, participatory action, feedback loops, and bottom-up approaches. And finally, coming from New Zealand, I'd like to finish with a whakatoki, naku te roro, nā te roro, ka ora ai te. With your basket and my basket, the people will live. But we weren't the first people to say that. So Aristotle had it years ago. The whole is more than the sum of its parts. So go the Greeks. They knew the answer right at the start. Oops, that one's an extra. So thank you very much.
Okay, stay here, Nikki. So I'm sorry, I forgot to say who I was to the audience who joined us remotely, and I'm Christine McCartney from NCIRS. But Nikki, I would like to just thank you again for an incredibly wide-ranging talk. And there's so many questions that I think we could ask, but I might hand it over to the audience first and see if people would like to throw Nikki a question, big or small. So it could be about proportionate universalism. Is that proportionate universalism? Or it could just be about a tiny thing about extraction from practice management software in New Zealand. Have we got any questions from the remote audience? You've wowed everybody. Oh yeah. Okay. Let's go in the middle with Pete first. I'm going to give you the microphone, Pete.
Hey. So I was just wondering, in terms of the micro stories. So I'm taking it you mean kind of agent-based modeling in terms of systems, like when you're discussing systems.
So you were asking about micro-narratives, yeah. That came out of qualitative research originally. And so you basically used the story of the population then to build your qualitative and your quantitative data into. So the micro-narrative is actually just the story. Okay, the story of the person who's living within the event or the community living within the event. It's actually just storytelling, yeah. And it's got a long, I don't know if there's qualitative researchers in the room, it's got a long qualitative history, but now we're trying to blend it into systems science. And there's some quite effective, the engineers got way ahead of us. They've been doing it for years. And so we're pretty slow to learn in public health, but that's where we're trying to take it, yeah.
Thank you. Just a quick question about the Global Vaccine Action Plan, particularly around Gavi funding, and because you were saying that the targets are, being met around introducing the new vaccines, but with new vaccines obviously comes a financial burden on countries, and I'm just wondering whether the action plan looks at these countries that are Gavi funded, that are these lower income countries that are changing into these lower middle income countries, and they're graduating, or they're supposed to be graduating from Gavi, but then new vaccines are being added, so they're really struggling to graduate.
Yeah, you got one of the problems in the nub. So I mean, one of the things is Gavi has, I think, to a large extent, driven the introduction of new vaccines. And historically there was this issue that if a country had low coverage, you wouldn't introduce a new vaccine. And then in terms of inequity, people said, well, that's unfair. You should still introduce a new vaccine. So they have done so, but often countries have not improved their coverage at the same time. And these countries now, as Gavi is planning, they're planning to graduate out of Gavi. Gavi is now becoming more and more aware that they are now trying to shift their focus less towards new vaccine introduction and more towards sustainability. So Gavi is getting more and more interested in issues like this about the challenge of improving coverage. Like one of the classics is around measles, that Gavi's been putting a lot of money into SIAs, so that's campaigns for countries that have got low coverage. But that's really rescue remedy, and measles committee, we're saying that's a rescue remedy. You have to do it to save kids' lives, but they're just doing it repeatedly, and the countries are not improving their infrastructure and their coverage. So Gavi is now recognizing that. They are worried about these countries transitioning out of Gavi. They are now softening their stance on that. So countries won't automatically just transition out of Gavi. They're softening their stance, and Gavi, particularly this year, its rhetoric is much more coming to us and saying, what can we do about coverage? Not just new vaccines. So the headspace is shifting a bit, but it's a huge worry. It really is. Countries do have to graduate out of Gavi, and many of them are struggling. Was there someone else, I thought?
Is there a question online? I'll give it to Lucy.
Thanks, Nikki. So an extension to the sustainability question, someone online's asked, how do you deal with the resistance to change from within the health services? So i.e., it's not my role, I don't have enough resources. Often we're dragging our feet or kicking down the can down the road, saying that's not my problem.
Yes, that's an excellent question. And this is where I do think complexity theory and system science really, really helps. So that person is probably quite correct when they come along and say, this is not my problem. This is my job description. I don't think this is in my job description. This is not my job description. So, or the problem's too big. So one of the things about coming back to the point of micro narratives and quality cycles is to hear that voice and to say, fair enough, that's actually a valid viewpoint. Rather than me getting really pissed off at that person, that's actually a valid viewpoint. And that viewpoint is coming from the lens of that person. So this is where our science system is going back to participating action and listening to the voice of the person who's saying, as you say, we're getting the results that the system has designed to happen. And if a person feels that they're disempowered and that's not their job, then that's from their perspective correct. So that's the starting point, I believe, where you can actually bring about change by listening to that voice and then deciding, often with that person alongside you, what you can shift. And often it's very small shifts that actually can make quite big differences, as some of the literature has shown.
So a more straightforward one. Someone from the audience has asked, what is defined as Asian in New Zealand? Might be very different to Asian in Australia.
Oh, and can I add to that? I mean, so if someone identifies as Maori and Asian, how are they categorised?
So Asian in New Zealand is essentially a third of the world, isn't it? Asian is people who identify themselves within countries that we consider within the Asian, and that includes Indian. So I know it's different from the UK one. So anybody who falls within China, India, all the areas around the Asian subcontinent, they then get dumped together in Asian, but we can disaggregate them into different subpopulations. Now, people are allowed to identify with as many ethnicities as they like. So if I come to you and say, I'm Māori, I'm Sri Lankan, and I'm Samoan, I will get prioritised to Māori, and then I'll get second prioritised to Pacifica. So that's the way New Zealand chooses to do it, based on currently their recognised need. Now, you could argue that may or may not be the right way to do it. So it's based on my opinion of what my ethnicity is, and then we rank Māori first, Pacifica second, and then others below that.
I mean, I'll be provocative, and you don't have to necessarily comment on this, but I would say that you know, one of the things that Australia looks to in your register is this. I guess the population is really categorised in these different ways with respect to ethnicity, and one of the, you know, limitations of our register is that we have very little data beyond you know, Indigenous, meaning Aboriginal, Torres Strait Islander, and non-Indigenous categorisations within our register. So one of, I guess what I'm kind of getting at, and maybe this is more of a segue to talking about how linked data can help in this space, is how can we use whatever we have, the data contained in registers, to better explore equity gaps. So, I mean, I know, and you talked about this at our 20th anniversary, is you know, linking to the registers, using the power of the system or the data to really better understand equity gaps. I mean, I'm fascinated about your recent decline in coverage and how that's going to be unpicked. I mean, how do you unpick when you see something occurring that's a surprise or not going like you'd like it to?
Yeah, so I think traditionally what we do is we just crunch the data by these big ethnicity groups or socioeconomic groups and go, wow, you know, we've got a drop in coverage by Māori. And that's the rhetoric going on in New Zealand at the moment. Now, I don't think that's particularly helpful. That, you know, yes, you can be labelled Māori and you can see a drop in coverage, but that doesn't mean there's a drop in coverage across all Māori. So you need to unpick it further and you need to burrow it down. And that, like, the New Zealand IDI now could give us the opportunity to go, which particular group within this bigger category is really the issue. And what we already know is it's, you know, if you drill down into it a bit more, you'll find that a lot of it's sometimes sole parents, people from the large urban areas, often people with lower socioeconomic, lower educational backgrounds. So you can start picking it apart, and no one of those things is the answer. It's not that Māori kids are in trouble. You know, it's that there's a certain subgroup that have Māori as part of their identity. So I think we're being too traditional black and white public health about this. And I think the New Zealand dialogue has to grow up a bit. And I'm really tired of us just saying it's a Māori problem, you know, and that I really want New Zealand to get a bit smarter. We've got the data, we've got the ability to link the data, we've got the ability to think about it, and we should be disaggregating. And we can do that much more effectively, you know, and you can disaggregate by many different levels. You know?
One more question. How are we travelling for time? We're okay. So I think maybe we can ask you a bit more about outreach services, because I mean, if you think about it, I guess at the global level, an SIA is a great big massive outreach service, isn't it? Not necessarily, you know, a very complicated one, but New Zealand have traditionally had more with respect to use of outreach services in certain contexts than I would say Australia have had. And so I think as we unpick some of those equity gaps, how do you see the place of outreach? And by that I mean, you know, the vaccine and the vaccine administrator going to the person rather than the person coming to them.
Yeah, well, it's interesting. The traditional SIA is not actually an outreach. You just go and vaccinate everybody, you know, and you disregard their records. Now, it's interesting that I find that a little challenging, and that I think Sri Lanka in particular kicked back on SIAs and said, look, if I've got a record of my kids vaccinating, I don't want you to come along and give them a 4th, 5th, 6th one, you know. But the countries are very low-income countries are very wedded to this concept that it's way easier just to go out and vaccinate everybody. Now, I think the world will eventually move beyond that, I hope. At the New Zealand level, we embedded it within systems so that you've got a system, you know the children, you know who they are. They're meant to go and get their vaccination at the provider. In New Zealand, that's the primary care, that's general practice. If they don't turn up in the general practice, then the system should smoothly work, that the general practice audits rapidly, realise the kids got lost, has not got them through their pre-calls and recalls, and within a very tight defined length of time, they should then send them immediately to the local outreach services that are funded by the local district health board, who then go out and knock on their door. So that's proportionate universalism. That's a universal approach with a proportionate outreach when you've lost the kids. Now, the system working well is fantastic. When it works well, it's a great system. Interestingly, our outreach services are reporting that these families are getting door knocked for a lot of things, as you can imagine. So that some of them, the security issues are getting bigger for them. A lot of them are gang backgrounds, a lot of them are pretty rough. And so when they come, they're not as welcome as they used to be. And there's a lot of other services lying up at their door. So they're worried about authority figures, they're worried about social welfare knocking on their door. So the actual outreach services are getting harder for the staff. So the concept works well for us, but the practice at the moment is getting, and I think that's my point about entrenched poverty at the lower level. So you might have a country that might not be getting poorer overall. New Zealand's not. We're getting richer, but the entrenched poverty at the bottom, I think, affects those sort of services.
I mean, that in essence is a fascinating narrative in itself, isn't it? So, I mean, I think the beauty of Nikki's presentation is that you always bring it back to the narrative, and you can tell a story, and you can imagine the family, and you can imagine the situation. So we you know, I would just put a plug and a shout out here for you know, Katrina Clark, who's our Indigenous Immunisation Coordinator at the national level, and so particularly within New South Wales, has been a hugely successful systems integrated approach to improving, you know, childhood immunisation coverage in Aboriginal children in New South Wales through integrating with systems to identify children, and you know, that's been recently published work, and I think that might be being actively looked at by other states and territories at the moment, which would be an excellent plan. But your point is, I think from your narrative, is to say, you know, think about what that involves for still the people that we want to do the most for and protect, which is at the heart of what our programs are doing. So think about, you know, what that means for them. Are they getting, you know...
Just to add to that one, when we started outreach services, the Māori community in particular said, I want people to come into my home and vaccinate my kids at home. You know, it's better for us, it's better for my kids, it works well. We can't afford that. You know, we realistically can't afford that. And that doesn't mean that you're offering the most expensive services to the highest needs families. So there was quite a difficult New Zealand dialogue where we said, no, you know, this is the routine system. You come to the general practice and you get vaccinated. We will offer services to those who get lost. But that's the thing about integrating it into a system. Otherwise, you get sort of a reverse equity problem where you get a sort of a Rolls-Royce system for a few. You know, so you've actually got to design it effectively and fairly for those who are still most likely to miss out. You know.
Do we have any more questions from our audience here? Everybody's just sitting here, I think, quite wowed and stunned by the depth and the breadth of everything you've been able to cover, Nikki. So look, in that regard, I think I'll just reflect on how privileged we've been to be able to hear you speak today. I think it's not often that you can go down from the story of the patient I saw a few months ago up to, you know, the global level and out to all sorts of theories and models to underpin such great thinking. So thank you from our audience to Nikki, and from everyone in the room. Thanks very much, Nikki Turner.